I'm glad to introduce our last speaker, Dr. Hans-Joerg, who is a very experienced pediatrician with a very sound experience in intensive care, pediatric intensive care, in both high and low income settings. He worked in London at the Imperial College, he worked in Malawi, he was part of the FIS study, and is currently working with us in our MSF projects on the field that we're very glad of.
Sorry. And for those of you who wonder, we're aiming at starting the lunch at 13:10, 13:15, something like that. Those who want.
And I think it's the perfect person to talk about how we can transfer critical care strategies from high to low income settings. Thank you very much, Hans.
Yeah, so I had the chance to speak earlier on, so this time I try to cut down the time a little bit. So I will follow up again on Lisa Umfrey's talk and the levels of care, because I think that is very, very important, and then follow up a bit on the speakers who spoke before me. So with the care we are delivering in hospitals, I think we need to be very modest and realize that factors determining child survival are associated with living conditions, primary health care. But hospital-based care still plays an important role. In sub-Saharan Africa, mortality among critically ill children remains very high, and most deaths in under 5s are related to infectious diseases. Nutritional deficiencies increase the risk of mortality, and as we heard before, most pediatric hospital deaths occur in the first hours or days of admission. Presence of impaired circulation or shock increases the mortality risk, and we also know that very basic emergency care interventions can reduce pediatric hospital mortality quite drastically, and if well done, even very quickly. Prof. Argent already talked about oxygen delivery and microcirculation, so I can move on. The initial basic steps in the International Sepsis Guidelines, as outlined by Professor Carcillo, are very basic. We talk about airway management, management of breathing, and delivery of oxygen. We give fluids or not. We correct hemoglobin. We correct electrolytes if we can, and we give antimicrobials as soon as possible. Early respiratory support is one very essential element of critical care. And in high-resource settings, we try to be very proactive. Use of peripheral low-dose adrenaline might then be the next step. Some of these very initial steps of the critical care algorithms can be done with excellence even in resource-poor settings. And these are some pictures from Eastern Congo. To be able to do this, as we discussed before, we need a very efficient critical care pathway, again with triage, emergency care, and further follow-up. Prof. Maitland talked about a FIS study and the increased mortality which was associated with fluid bolus management. We also know from Mike Levine's talk that respiratory dysfunction might have contributed to increased mortality in children in the FIS study. And we also know that children with severe anemia and neurological conditions need particular attention. Recently, WHO reviewed guidelines on management and shock and defined a term called impaired circulation, and also defined criteria for supplemental oxygen and saturation targets. Depending on available resources, we then can try, and that's a suggestion or an idea, we can try to move on a little bit. Non-invasive ventilation might be an option. Low-dose adrenaline might be another option to think about. To do this, and here we come back to Lisa Umfrey's talk, we need to define critical care levels. And here we called level 0 in Lisa Umfrey's presentation, we call it level 1. But it's basically a unit where we apply basic emergency care as outlined by WHO and MSF. We can do spot checks of vital signs. We have a certain nurse-to-patient ratio, maybe 1 to 10, if we are lucky. We have a clinician who can do regular ward rounds. We have training modules, and we might have low-flow oxygen, a good blood bank, and point-of-care tests. Low-flow oxygen, there was a good study done by Trevor Tugh in Papua New Guinea, showed that even 1 to 2 liters per minute can improve outcomes in children with severe pneumonia. And WHO also published some nice specifications on oxygen concentrators and oxygen therapy. With relatively minimal resources, and that's just an idea, we might be able to improve quality quite significantly. We still might provide basic critical care, but we might have more and better monitoring. And we have more nurses per patient. We might be able to provide high-flow oxygen. To provide high-flow oxygen, we need more resources. We might need 1 concentrator for 1 child. And this might still not be enough, because the child with pneumonia might not only need high-flow oxygen, we might have to re-recruit collapsed air spaces, and we might have to try to keep these air spaces open by, for example, applying non-invasive ventilation, but only if we are able to provide this initial basic care. A level 3 unit, that would be a unit where we intubate, ventilate, give central inotropes, and maybe even peritoneal dialysis. That's a big step up. It needs much more resources, it needs much more training, and it needs much more staff, health workers. This might not mean that it's impossible. This is an example from a hospital in northern Uganda. But it might not be a priority in most settings in which MSF works. So back to respiratory failure. Respiratory failure can be associated with pneumonia, bacterial infections, viral infections, a single organ failure. These children might have a very good chance of survival if they get oxygen, plus minus, non-invasive support. But respiratory dysfunction can also occur with multi-organ dysfunction as part of sepsis syndrome. And we might have worsened maybe respiratory function by giving volume plus minus transfusions. We also find children with severe respiratory distress, which might actually, at least at the beginning of the disease process, have normal lungs, but present with severe acidosis, typically the child with severe anemia, malaria. Reduced oxygen delivery, reduced tissue oxygenation, subsequently that child might develop a metabolic acidosis, which might be associated with deep breathing and respiratory distress. That child might need a lot of his energy and oxygen consumption just for the work of breathing which is needed. 2 minutes, okay, so this is very complex anyway, so we skip it. So, what do we want to achieve with non-invasive ventilation? We try to improve ventilation perfusion mismatch. We try to improve gas exchange. We try to reduce work of breathing and oxygenation. And we might have a little effect also on afterload for our circulation. Important, NIV will not replace ventilation in a child with poor respiratory effort. How does CPAP work, or how could it work? If we have a diseased lung, we might have very stiff lungs, atelectasis, airway collapse. And by applying positive pressure to the lung, we might shift the working point of a lung of a point of poor compliance to an area of better compliance, better gas exchange. What options do we have? We have CPAP. A simple option is bubble CPAP. We have high-flow nasal cannular oxygen, and we have more complex NIV options like bilevel positive airway pressure, or even something called NAVA, but we will also skip this one. So again, bubble CPAP options, multiple options are available, but there are probably realistic costs, and maintenance is also realistic. We have setups where we can determine FiO2. I will skip this also. We have a few studies showing that it's feasible to provide NIV in neonates. There was a very nice study done in Malawi by Prof. Molyneux and team, and there were other studies looking at feasibility. One of them I presented earlier on. A very important study was done by Christie and Tuke in Bangladesh, a randomized controlled trial comparing bubble CPAP, a form of high-flow nasal cannula oxygen, and low-flow. And the bubble CPAP did significantly better. High-flow nasal cannula oxygen, we use very high flows, 2 liters per minute in children under 10 kilo, and we add on a little bit for the bigger children. I will skip the rest here also a bit. So CPAP can be used in single organ dysfunction, but also in terms of a care package for the critically ill child. And obviously, we need more research on this. There's a study ongoing in Salima, in Malawi, looking at children with respiratory dysfunction and undernutrition. And Prof. Maitland is also doing a study, COAST, using low-flow oxygen and high-flow nasal cannula oxygen. Just a few words, just 53 seconds, to shock and fluid refractory shock. As we heard from previous speakers, the description via the Frank-Starling curve might just be too simple, but in a way that's the concept we are using a bit. We might have a dependence of cardiac function depending on preload, and our understanding was if we give volume, we can maybe improve cardiac function. We reassess, and that's important, either by clinical assessment, or we might even use in a research context some non-invasive methods. However, if we reach a point where we fill the heart and still don't have optimal cardiac output, so-called fluid refractory shock, what do we do then? And one moment. So what are our options in low resource settings? Well, I think we need to go back to basics, airway breathing, oxygen. We could consider NIV. We optimize our hemoglobin. We could consider correction of calcium. There's discussion about thiamine. I think that's also very interesting. Review article from Laurent Hiffler and a team of Daniel Martinez. And at this level, we could consider maybe low-dose adrenaline. And just 2 sentences to that. What level could we use? Low-dose adrenaline would be 0.05, 0.3 mics per kilo per minute. At that level, we have mainly beta-1 activity, mainly inotropic effect. But we need to consider risks, extravasation injuries. If we overdo it, we might actually increase oxygen consumption. We might have an effect on lactate and sugar. How do we deliver it? MSF Swiss and France suggested, I think, a very nice protocol. Do we need infusion pumps? Good. Yeah, here we go.